Welcome, everyone. We'll be getting started in just a few minutes. I know that we have some others continuing to join. But while we're waiting, I'm Cindy Carlson. I'm part of the clinical task force and chair the clinical core steering committee. And we want to welcome you to the second of our webinars on trying to implement UDS4. So really focusing in on questions that you all have raised during various sessions. So we're thrilled today to be able to have a panel discussing operationalizing impaired, not mild cognitive impairment, or not MCI. So in our session today, we'll be led by Dr. Greg Jicha. Dr. Jicha is a neurologist who also has a PhD in neuropathology from Einstein College of Medicine and has done residency training at Mayo Clinic and fellowship training there as well, and now is clinical core leader at the University of Kentucky Alzheimer's Disease Research Center. And we're thrilled also to have Mike Rafii and Lisa Barnes and Sandra Weintraub speaking as well. Despite internet challenges and illnesses, we're really thankful to have everyone here today. So I'm going to turn it over to Dr. Jicha and welcome our other panelists to this discussion today. Oh, before we move on, we do have some other resources coming up for training for UDS4. So of note, we will have a training session a week after our ADRC meeting. That will be on May 14th. It's scheduled from 11 a.m. Eastern time to 4 p.m. Eastern time. So it's UDS4 virtual training workshops. So we encourage everyone to participate with your teams. So whichever teams it's relevant for, the clinical cores, any data core members, whoever wants to join from your teams. But again, this will be a hands-on workshop. We really want people to kind of block out their time and be a part of this. It will be recorded, but we do want to make sure that people are engaged actively so we can make sure that we implement this in a way that's consistent across centers. So with that, I'll turn it over to Dr. Jicha. Thank you.
Very good. Thanks, Cindy. And please, always, Greg, for everyone in the ADRC community. I'm really delighted to be joined today by the other members of our expert panel who all have areas of tremendous expertise that I simply do not have. So I think we'll have a comprehensive overview today. Hannah, can I have the next slide? So what we're really talking about, this category, which currently we know on UDS 3.0 is impaired other, meaning, there's some sign of impairment, but they don't meet our individual criteria for MCI or dementia or normal. And so this is actually data that NACC pulled from the Alzheimer's disease centers, and each center is depicted here, and where we can begin to look at the variability from center to center. And I will say, I'm always really impressed, when one center says this person is normal, they are going to be normal at virtually every one of the ADRCs. And the same holds true, even though MCI is controversial. When we say MCI, we all generate a relatively homogeneous population that kind of meets that criteria, and likewise for dementia. But when we look at this category impaired other, we've got a spread with MoCA scores, from a mean of 18 all the way up to, 25. And so this is much more heterogeneous. And we found from polling the centers that people use this in different ways. And so moving forward to UDS4, we really wanted to garner a little more information and operationalize how we're using this so that we could potentially explore some of this. So that's really what we're going to try to do today. Next slide, Hannah. So as I always say, the way that impaired other exists nowadays is kind of like the dumpster. Everything's just kind of thrown in there, but really parceling this out and making this a useful diagnostic category can help improve our science, especially our understanding of pre-existing cognitive or functional states, non-classical forms of dementia. Hopefully this will spur research. Next slide. So let's take a look before we jump into impaired, not MCI. We should make sure that everybody's on board with where we are with MCI in the UDS4. And so really, we have a 3-item checklist. Check all criteria for MCI core criteria. So we want to know that there's a clinical concern about decline in cognition compared to the participant's prior level of lifelong or usual cognitive function. So we're really looking at, this could be based on input from the participant, co-participant, the clinician's judgment, the CDR, something's changing in this person. Criteria number 2, is there actual objective impairment? Is there impairment in one or more cognitive domains compared to their estimated prior level of lifelong or their usual cognitive function? And then number 3, obviously largely preserved functional independence or functional dependence not related to cognitive decline, like macular degeneration and I can no longer drive. We wouldn't consider that. So it's really the core criteria for MCI. Do we have cognitive change? It is a change from what was done previously, and we don't have enough functional disability to meet criteria for dementia. And so very straightforward, does not consider suspected etiology, pure clinical diagnosis in Form D1. And we're all familiar with this, but it's important just to reiterate as we move in. Next slide, Hannah. So also we have this new category in our last webinar with Kostas Laketsos reviewed MBI criteria. If you missed that webinar, it is recorded on the NACC website, so please do. This is also a new category, and so somebody may not be normal dementia or MCI, but could be MBI. So this is a change in a participant's affect, motivation, thought, content, behavior, personality that has been present for at least 6 months, typically late onset, not a lifelong kind of a pattern or problem, not explained by delirium or another DSM-5 psychiatric diagnosis, although the symptoms may overlap with those. And that, again, there's largely preserved independence in functional abilities, but that the symptoms are starting to potentially become problematic. And then picking domains. So very, very important. So at least as we're working through this, you can have MCI and MBI. You could have behavioral changes. You could be impaired other not MCI and have MBI. But you can't have dementia and be MBI. And so very, very important. So again, if folks meet criteria for MBI, Form D1b, you'll specify the suspected etiology. Next slide. I do think we need to mention at least SCD criteria, right? Because this is another new category for us. Somebody who has cognitive complaints, but unimpaired cognition and unimpaired behavior and no functional decline. So question 2A, if someone has concerns about changes in cognition, but they're cognitively normal and they have no functional decline, then they actually meet the criteria for subjective cognitive decline. Not operationalized well, but we do have some objective SCD questions in Form A1 and A2 participant and informant demographic sections. So we will have some objective SCD data as well. Next slide. So now we get really into the meat and potatoes of what we're talking about today, which is this impaired, not MCI. This is a criteria for when we don't meet all 3 boxes for MCI, but it's not just the cognitive complaint, which would be SCD. So in essence, this really is looking at people who have abnormal cognitive test scores, but no concern, no complaint or functional decline, or perhaps long-standing cognitive difficulties, so their testing is abnormal, but this isn't really a change from their usual function. We wouldn't say that they're MCI because they had a lifelong disability. So very, very important. And in some cases, we may actually have significant complaints of functional impairment, not just cognitive impairment, where we might say, my God, there's cognitive complaints here, but this is beyond that with functional impairment such that they may warrant, a CDR sum of boxes or a functional assessment scale score greater than 0, but the cognitive testing is still normal. So what do we do with these cases? And we've thought about that. And so really, people that fit these criteria don't meet the criteria for normal because they have an abnormality, don't meet criteria for SCD because there's something else going on, but don't make it all the way to MCI. So then I think that's a reasonable way to think about this. Next slide. So we can go through a few quick cases. This is a 74-year-old male, hypertension, some prostate issues, generalized anxiety disorder, hearing loss. It's all been chronic, always been anxious about testing. He's been in our cohort for years, always tested normal previously. Well, his UDS visit was poorly timed. He was flying home the night before from Europe on a red-eye flight, and he was a little sleep deprived, and that augmented his anxiety. And so he popped one of his alprazolam an hour before leaving home for the clinic visit. And by the time he got here and pulled into the parking lot, he was even more anxious and popped the second one. He came in, was consented, had his blood drawn, everything, looked reasonable. The patient and the informant said, nope, doing rock solid, doing great. On testing, he kept dozing off in the middle of tests, and they did note slurred speech, clued the clinician in, said, hey, I think maybe he took too much of his alprazolam. The clinician saw him and suspected some benzodiazepine intoxication. He did score abnormally on multiple tests as well. Now, we did bring him back at a later date for that, but next slide. So we think about this case and say, well, there's no subjective cognitive complaint. All right. We don't know what to do with his testing is questionable. So the tester really has an act here in UDS4, and that is on Form C2, question 18, they are going to mark down, I think this is probably an invalid score. They flew home on a red eye. He took some extra Xanax that he shouldn't have had on board. And so they're going to flag this here. And the neuropsychologist takes that into account, as they always do. Nonetheless, without repeating the testing at another time point, the scores are abnormal. Next slide. So how we're going to handle this on Form D1 in our cognitively impaired, not MCI or dementia, is exactly in this way. Now we're seeing cognitive testing is abnormal, but we really don't have a clinical concern or complaints of functional decline. We think he's a little sleep deprived and overdid his Xanax today. So he would meet very straightforward criteria. Clearly, we wouldn't think, that he has MCI or dementia on the basis of such a presentation. And so repeat testing longitudinally for this gentleman without sleep deprivation and benzodiazepines on board, right back up into the normal range again. So this may be a type of example where we may use cognitively impaired, not MCI. Next slide. In case study 2, an 82-year-old female, no significant past medical history other than 10 years of estrogen replacement therapy following menopause. She's off that currently. She does have significant cognitive complaints meeting SCD criteria. But on questioning, both the participant and the informant had some significant functional complaints that they attributed to cognition and no other cause, leading to a functional assessment scale score greater than 0. That's Form D7. Testing her, she did great, cognitively normal, and all other aspects of the visit were unremarkable. Next slide. So now we have somebody who we can look at for SCD criteria. Does the participant have unimpaired cognition? Yes. Do they have unimpaired behavior? Yes. So we'd consider in question 2A subjective cognitive decline, but then part 3 of that is no functional decline, and the abnormal function evidenced by the FAS score in a case like this may preclude the criteria for SCD. So where are we going to go? We got to go somewhere else. Next slide. So D1a can portray this as cognitively impaired, not MCI, where we can say there's evidence for functional impairment that's been attributed to potentially cognitive changes, but the cognitive testing is normal. In such a case, the abnormal function would merit that criteria. So again, some aspects of an MCI or dementia syndrome, but not meeting full criteria is kind of what cognitively impaired, not MCI or dementia means. So some very straightforward examples, but next slide. I really want to bring our panelists in, and our first panelist, Mike Rafii, is really a leader in the field of Down syndrome and the national consortia for this. So I've asked Mike, because many of us do have folks, and I do think Down syndrome is kind of a prototypical case where we might consider this diagnosis or others. So Mike, thank you so much for joining us today.
Thanks, Greg. Can you hear me okay?
Yes.
Great. All right, so this is, first of all, thanks for inviting me to present this case. This is a 42-year-old female with Down syndrome with an IQ of 68 and a history of childhood seizures, no longer on any treatment, who also has coexisting obesity, hypothyroidism, being treated with Synthroid. She's employed full-time at a restaurant and has been having non-progressive difficulty folding napkins with silverware inside for about 6 months. So there's some restaurants, they have the silverware folded in a very unique way. She continues to have trouble with this, but it doesn't seem to be getting worse. She continues to take the bus home and let herself into her group home with her own key, but on 2 occasions, she had gotten off at the wrong bus stop and needed to call the group home staff to be picked up. There were no issues with memory, language, or thinking. Her best friend moved to another city about 9 months ago. She has full ADLs, but has always needed assistance with most of her IADLs since moving into her group home about 11 years ago. There are no behavioral issues. You know, sometimes she would occasionally get sad that her best friend moved away, but they still were able to keep in touch. Her appetite, weight, and sleep were normal, or at least unchanged. And her score on the modified cued recall test remained stable at 31 out of 36 total points. And the diagnosis here would be not impaired, not MCI, per the instructions for question 5B. This individual has intellectual disability, lifelong intellectual disability, and has had occasional issues, but certainly attributable to extraneous factors. Next slide. So when you're looking at this category of impaired, not MCI, we would check off that there is evidence of functional impairment, but cognitive testing was judged to be normal, and I'll show you the ranges for cognitive testing. Cognitive testing can be abnormal, but there's no clinical concern for a functional decline, and there are long-standing issues with this participant, given that they have underlying intellectual disability due to Down syndrome. So they are clearly impaired, but there doesn't seem to be a progression, meaning more frequent issues with getting into her apartment, more frequent issues in terms of being able to get home on the bus, more progressive or frequent issues with doing her job at the restaurant. So those are certainly not meeting those criteria. And individuals with Down syndrome may have behavioral changes manifesting as symptoms of Alzheimer's disease, but those would bring you to the end. Next slide. So I just want to give a brief overview. There is a big interest in having ADRCs bring in individuals with Down syndrome. NACC has a Down syndrome module. Please consider getting involved. ACTC and ACTCDS are establishing many studies to support bringing the latest therapies to this population that is the world's largest genetically endowed population for Alzheimer's disease. The mean age of dementia diagnosis in people with Down syndrome is 54 years. You really need to perform baseline cognitive and functional evaluation prior to age of 45. The most widely used informant-based assessment is called the NTG-EDS. That's the National Task Group Early Detection for Symptoms of Dementia. This has been translated into 11 languages, is freely available, and you can use it in your clinic. The modified acute recall test is probably the most promising direct testing for early AD-related memory changes. And again, I just want to raise awareness that these are out there and can be utilized. Again, a reminder, the emergence of memory issues, sort of like amnestic MCI, is the most prevalent form of the clinical manifestation of Alzheimer's disease, more so than behavioral symptoms. Behavioral symptoms in people with Down syndrome are either related to Down syndrome, extraneous, or maybe a late manifestation of Alzheimer's disease dementia. Next slide. So the largest longitudinal cohort of individuals with Down syndrome that's being followed, analogous to ADNI, is called ADCDS, Alzheimer's Biomarker Consortium Down Syndrome. This is 500 individuals with Down syndrome who are getting MRIs, amyloid PET scans, tau PET scans, plasma biomarkers, and cognitive tests. And there's a consensus panel that reviews cognition and function and gives them a consensus diagnosis. And here I have on the x-axis the age ranges from 25 to 64, broken down into buckets of 5 years, with the y-axis being the prevalence of a particular clinical diagnosis. And look at the blue line. That's cognitively stable. And you can see that up until about the age of 45, most individuals are cognitively stable. Now they're cognitively stable, but they may have intellectual disability. And these individuals around the age of 45, you see the prevalence of cognitively normal drops, such that by the age of 50, about 50% are cognitively stable, 50% are affected. And the way they're affected could be MCI or dementia. Those categories are now validated for people with Down syndrome, and you can see that those start to increase in their prevalence with age. Just a reminder that the people who are on the blue line, who are cognitively stable, will inevitably develop amyloid plaques, and those that do are preclinical AD. And these are individuals that have for long been neglected for clinical trials targeting Alzheimer's disease. So I just want to bring this to your attention. These people can participate in longitudinal studies, and ABCDS is providing very important data about this. But until the age of 50, you're really not worried about dementia in this population. Next slide. And then this slide just shows the modified cued recall test. This is kind of like a PAC, a very sensitive, early, direct test of cognition in people with Down syndrome. And you can see again on the x-axis are the age ranges, and there's a y-axis is the mean score on this modified cued recall test. And there's a vertical dashed line, that's the average age of dementia diagnosis. And there are two horizontal lines, a solid line and a dashed line. Those are the proposed cutoffs between, for the dashed line between cognitively stable and MCI in Down syndrome. And then the solid line, which is the cutoff between MCI and dementia. So score of 22 or less is consistent with dementia. And there have been several papers published validating this. And I just want to bring your attention to those standard error bars. Look at how tight those standard error bars are. This is an excellent test. Does not take very long to administer and seems to have very good internal validity. These proposed cutoffs will be validated even further in ongoing clinical trials. So I would just point out again that by around the age of 50 is when you start to see the mean score dip around the dementia cutoff. So if you have a person with Down syndrome in your clinic or in your cohort, and they're having significant issues, cognitive issues, functional issues, and they are younger than the age of 50, it's quite concerning that there's something other than Alzheimer's disease as the cause of their decline. But over the age of 50, there's a very high likelihood that those changes are there. Next slide. I'll hand it off to the next one.
Fantastic. Thanks, Mike, for sharing that with the group. Certainly, these are complex cases, and if we have folks in our cohort that fit these areas, working this out of how we're going to assign diagnoses is incredibly important. So I'd like to welcome Lisa Barnes, who's been working on the CTF for years now, practically an eternity, it seems like, as we've prepped for UDSv4, who has brought up many tremendous insights that have helped shape what we're doing. And I really asked her to come present today some other cases that make us scratch our heads. So thank you, Lisa, for coming.
Thanks, Greg. And thank you for the invitation to be a part of the panel. And thank you to the Clinical Core Steering Committee. So I was asked to focus on underrepresented participants for my case examples. Our center focuses on African Americans and Latinos, but my two examples today will be of older African Americans. So this first case is a 74-year-old African American woman with 16 years of education and an annual income ranging between $15,000 to $19,000 per year. At the baseline evaluation, she had no memory complaints and no functional impairments. Performance on the cognitive tests were all within the normal range for her education level, except for visual spatial ability, which she showed mild impairment on some of those tests. At that visit, the neuropsychologist reviewed the algorithmic ratings for the various tests and made a clinical judgment to disagree with the algorithm for the visual spatial domain and upgraded performance in that domain from mild impairment to possible impairment. During the follow-up, she performed within the normal range on all of her tests except visual spatial, where her impairment was somewhat inconsistent. Some years she performed within the normal range, other years she was impaired. The graph on the right shows this woman's performance on a Z-score global composite measure that includes all of the tests across all of the domains. So from baseline to year, she was in the study for 12 years. And as you can see, there is bounce in her performance over the years, but not much evidence of meaningful decline. Next slide. So you've seen this form before, and this is our impaired, not MCI. And so when we look at this person, we would fill this out as checking the box under 5 for cognitive testing is abnormal, but there's no clinical concern or functional decline. And 5B, does this participant meet criteria for cognitively impaired, not MCI or dementia? The answer is yes. And that's because, she does score abnormally on the visual spatial tests, but we really don't have any evidence that there's any clinical, behavioral, functional decline. So she would not get a diagnosis of MCI or dementia. She may still have behavioral changes, and then that would take us to the questions for MBI. Next slide. Okay, my second case is a 70-year-old African-American woman, 12 years of education, and an annual income between $15,000 and $19,000. This person has mild visual impairment, but she reported no memory complaints at baseline and no functional impairment. She, because of the mild visual impairment, which was self-reported and then documented by the tester, she does need some help with some of the functional activities of daily living, like, some of the housework type things, but nothing major. On her baseline evaluation, she performed in the normal range on most cognitive tests. She had a little trouble on tests that had a visual component, but was especially impaired in the visual spatial domain. Her performance in that domain got gradually worse over time, and in some years, those test scores were missing because she couldn't complete the tests. The neuropsychologist, again, disagreed with the algorithm for that domain, that she was impaired, and rated her as possible impairment. The graph on the right shows her performance over time on the global Z-score composite measure. And for the most part, it looks like her performance is trending up over time, but you really don't see any meaningful decline. Next slide. So again, we would fill the form out in a very similar way. We would mark the box that cognitive testing is abnormal, based on her visual spatial and some of the other tests where, she had trouble, but it's because of her visual impairment. But there's no concern, or functional decline. So, and then we would, mark yes, that she has impaired, not MCI. But again, it's because we're questioning the validity of some of those tests due to her marked visual impairment. And again, she might still have behavioral, issues that we could fill out in the other forms. Next slide. So, at our center, the neuropsychologist is making a clinical judgment to, upgrade performance when it's isolated to select cognitive domains that we think are more likely to be affected by cultural or social factors. And we have certainly published a lot, looking at different contextual factors that seem to affect performance in older African Americans. But we were curious to know how that decision that we're making is affecting our measurement of cognitive decline in our older African Americans. So this graph shows results from a linear mixed effects model of more than 1,000 African Americans, and is adjusted for age, sex, and education, and also an indicator for whether their performance was upgraded or not. And so the red line are participants who received an upgrade at some point during follow-up, and the blue line are those without an upgrade. And it looks like those who received an upgrade they're performing at a lower level at baseline, which you would expect, but they're declining slower over time compared to those who did not receive the upgrade. So sort of, suggesting that these people really don't have MCI. Next slide. So, African Americans, they may show impairment on isolated tests or cognitive domains, but we really think that this is due to social cultural factors. There's a ton of literature, supporting this fact or this conjecture. We instituted upgrades in performance when impairment was isolated to domains of visual spatial, and in some cases, language domains, because those are the domains that we have the least confidence in as far as really reliably measuring cognition in older African Americans. The individual trajectories of participants who received an upgrade show little evidence of decline over time. And if we looked in the full sample of African Americans, those who received an upgrade in performance by the neuropsychologist actually declined at a slower rate than those who did not receive the upgrade. Now, the nice thing about this new category that we have now is that we now have a place to put these types of participants. In our center, we have tended to call them normal because we don't think they have MCI, but clearly they are in that in-between stage. And so, now we'll have a way to categorize these people and then be able to study what are some factors associated with, with their category and how they change over time and biomarkers and all of that. So I will end there and turn it over to Sandy.
Fantastic. So our next speaker is Sandy Weintraub from Northwestern. Sandy, thank you so much. You've really been an icon in the field, and I really thought of you when we were going through this, that gaining your insights would be really, really important for the panel today. So thank you.
Thank you, Greg, for your compliments, and also thanks everybody for inviting me to this. I have to apologize. Lisa named me Kermit the Frog. I got the flu when I was in Lisbon, so bear with me. Next slide, please. So, whoops, I'm sorry, go back one. I think that was my first slide, yeah. I picked these cases because I'm not sure that I can resolve them even with the new criteria. And so I wanted to share these with everybody because I think that this is the real everyday problem that we have when people are coming for their annual visits and they're not quite in one category or another, and we don't know what to do with them in the middle. And I picked two cases that have longitudinal follow-up. The first one was a 74-year-old Black woman with 12 years of education. She worked as a finance administrator. She had her first visit in 2012. At that time, the CDR was 0.5 because both the participant and the study partner were describing complaints of memory changes that were not normal for her. All of her test scores were at least normal, if not better, for her age. In subsequent years, however, the CDR was 0 until 2020. And then in 2020, memory and judgment were both endorsed by the study partner and the participant, but the cognitive test scores remained largely normal. Next slide, please. This is a very busy slide. It seems to be falling off the side of my screen, but maybe not. Everybody can see the full screen?
Yes.
Great. So on the left, I have a chart showing all of her visits, and I just included the sum of boxes for the CDR, and then little notes about why we gave her those sum of boxes scores, what things were endorsed by the patient and, this participant and the study partner. On the right, we have longitudinal follow-up, and I selected several tests, the Ray, Trails, Animals, BNT, and then the CDR is on the bottom. And in the top panel of the Ray, those are raw scores. And so you can see that this participant was, the blue line indicates above average, the bottom line indicates below average. Between there indicates the normal range for age for that person. And you can see that her Ray scores are really going along pretty well until the very end. Trails, I'm not sure why we only have partial scores there, but really, again, within normal limits, except for one blip. Animals, pretty steady. BNT score, a little bit of decline, but still normal for age. And then the CDR, we have this 0.5 in the beginning, 0, 0, 0, and then 0.5. So this participant, because of the complaints, because of the evidence that there were some changes, and I didn't include the FAS, but there were some things endorsed on the FAS as needs assistance with things. This is the person that we would call impaired, not MCI. But is this person impaired? I put that out there as a question. Okay, next. Also, I just want to call out Daniel Gutstein, Kate Lafrasha, and Debbie Zemlock, who helped me make these beautiful pictures. Next case study is an 88-year-old white woman, 12 years of education, airline ticket agent. Her first visit in 2011, again, CDR 0.5 due to participant and study partner complaints. And it was in the areas of memory, judgment, home and hobbies, and community affairs. Test scores were again, and this was a person because of her age, kind of qualified for our super aging protocol, because you have to have a race score at least average for somebody in their 50s or 60s, if not better. Subsequent years, again, a CDR of 0 until 2018, and then the CDR popped back up to 0.5. But again, cognitive test scores remained largely normal for age. Next slide, please. And you can see, again, the CDR sum of boxes across the different years. And then the Ray scores, she popped above that super ager score of 9 on delayed recall for the Ray auditory verbal learning test, which is quite remarkable. Normal scores in other domains, but then that CDR keeps popping up and down. So again, impaired, but and warranting a CDR of 0.5, but not impaired in any of the cognitive testing, and maybe a little downward trend, but not sure that that is adequately captured by impaired, not MCI. Thank you.
Thank you, Sandy. That was fantastic. So clearly some food for thought out there today as well. I did want to make a correction on some of the summary slides for my 2 cases and for Mike Rafii's. There's a typo on them where the box was checked that they were not impaired, not MCI, but it's the other way around. So I apologize for those typos, but we'll open that for discussion. So again, this is a difficult diagnostic entity, but one can see, that we could have somebody who has cognitive impairment, but no complaints and no functional decline, and we really don't have a place to put them. And we can see patients where, or participants where the CDR is clearly a 0.5. It's not just a subjective cognitive complaint. There's more going on than that, and yet the cognitive testing remains normal. And now with the use of this form, we'll be able to figure that out. One will be able to ask questions. I'd like all the people that don't meet criteria for MCI, but have objective evidence for abnormal test scores, and we can start to ask questions about that group and or the other etiologies. So so I think there's utility to this. I think if we can get us all working together in a systematic fashion, we're going to make some sense out of these folks that never cleanly fit into any category previously. So next slide. So I think that's it for our presentation today. So really, to open this up for discussion, and remember, UDSv4 is intended to be a living document. So and those forms are in final shape right now. This is how we see this diagnostic category working for us, but love input and discussion on these cases.
Thank you, Greg, Lisa, Mike, and Sandy for that presentation. We have quite a few questions. And again, I just want to reemphasize what Greg just said, that a lot of this, we already had categories for MCI, impaired, not MCI, and normal. And now it's going to help us kind of differentiate those questions that I think we're all kind of grouping, categorizing in different ways across sites. So hopefully it'll help us to refine our diagnostic criteria as we move forward. So we have a question from Jim Law about, given the variability in how participants and study partners might report functional limitations, he's wondering why wouldn't we call the second case, Greg, normal?
Well, I'm sorry, Cindy, would you repeat that?
Yep, so it's in the Q&A. So Jim was wondering, given the variability in how participants and study partners report these functional limitations, why wouldn't we call the second case normal? So
Oh,
again, variability
okay.
in reporting.
Yeah, I think that I think number one, I think when we have significant cognitive complaints without cognitive or behavioral decline, then yes, could they be normal? Are these cognitive complaints sufficient to push them into thinking about subjective cognitive decline, or are they beyond that when reflected in an ultimate FAS of 2 or 3 rather than 0, and or a CDR of 0.5 rather than 0? So I do think it's tricky, and there is a judgment call as to when cognitive complaints cross a threshold where we're really concerned about impact on function and abilities, and that is what pushes us to an impaired categorization.
Greg, I may have misunderstood the case, but my understanding how you presented the case was that CDR was 0. There were no cognitive impairments, but there was a report of some functional limitations. And I think we've all seen participants and study partners who may be, have different characteristics, relationships, and may report things in sort of a hyper-vigilant manner, and might say that, yeah, I've had to do X, Y, or Z for my husband because he's doing whatever, but everything else looks perfectly normal. And I'm inclined to say that, FAQ of 2 means nothing, and that this participant is normal.
Yeah. And I think that's a judgment call, Jim. That needs to be made, on the ultimately, the clinician is going to make a judgment that's going to categorize folks appropriately. And I think that's kind of like the first case that I presented. There's a question about the validity of the data that we're receiving. And I think that's an important point.
We do have some spots for variability in reporting, for you to check if there's concerns about, validity of the data from the care partner or the study partner or the participant. But you're right, there's going to be some cases where the clinician suspects over-reporting. So we have a lot of other questions. So Andrea Bazaki says, I have suspected FTD patients who qualify for MBI and may have functional decline due to their behaviors, but test normal neuropsych testing. For suspected FTD qualify for MBI, but they have functional decline due to behaviors and neuropsych testing, or testing normally at neuropsych.
So if they meet criteria for MBI, then they would be MBI. I don't know. I see Costas is online with us today as our MBI expert. I don't know, Costas, if you'd like to weigh in, albeit not a listed panel member today.
Yeah, I think your answer was correct. If you have MBI, you have MBI. But I think you could also have MCI, impaired, not MCI at the same time, right?
I think you could if you had a functional decline that you felt was not caused by the behavior, but might be more related to cognitive decline. You're not objectively picking up on testing. That certainly could be a possibility.
But these are judgment calls, and I don't think that, that they need to be made in case by case.
The next question is, so for cognitive impaired, not MCI, someone who has impairments in neuropsych testing, so impairments in neuropsych testing, but no significant functional impairment. So CDR, sum of boxes is 0. What if someone has a lower impaired score in one memory task, but it's less than 1.5 standard deviations compared to the mean? So it's a subtle decline, but all their tests are fine. There are reports that this person may have mild or questionable changes in memory. So the CDR may be 0.5, So then what do we do? Do we call them cognitively impaired, not MCI?
I think this gets into some nuances of neuropsychological test interpretation. I'd like to defer to my neuropsychologists on the panel to consider this when dealing with standard deviations and change.
Lisa, do you want to respond, or can I go ahead?
Yeah, go ahead, Sandy.
Yes, sorry. So I think that this is where we're kind of putting together the functional impact and the actual cognitive deficit, trying to combine them into one thing and come up with a single diagnosis. I mean, this is, like it was a Jim who said that there's a lot of clinical interpretation that goes into this. You see somebody and they're scoring perfectly on everything, and then they have one test where their memory score is 1.5 standard deviations below the mean. Does that make them impaired? I wouldn't say so.
Yeah, I think that ultimately on Form C2, the neuropsychologist makes a decision as to level of impairment based on validity measures and the like. And so I think it's important, when somebody has an abnormal score, it's got to go into the database, as an abnormal score. But we need to know how to use that in our future data requests, and that's why making sure we appropriately categorize patients to the best of our abilities will help us do the best science afterwards.
Yeah,
Yes.
and I'll just add also that, it's just one test. And most of us have multiple tests in these different domains. So I would certainly look at all of the tests and trying to figure this one out. But I agree with Sandy. I probably wouldn't call this impaired just because of one test. And you said it was less than 1.5 standard deviation. So it's not even, greater than 1.5. So.
Right. I think this gets to a lot of the questions that are in the Q&A section, is the role of clinical judgment over some of these criteria. And I don't know if some of the panelists want to address that. Again, you'll have a clinical diagnosis of how you're putting this all together as a clinician, but then also there'll be elements that you're checking off about what's included. So I don't know if the panelists want to address that again, the big picture scope of how does clinical judgment interact with some of these, check boxes or criteria.
Yeah, I think that's important, and that really is the crux, and does seem to be a lot of what people are asking. There's a lot that we do that, yes, we'd like to just have rock solid operationalized. So it was like a machine, but we're dealing with real people in the real world, and we all know that doesn't work. There will always be a role for clinical judgment. There's a role for clinical judgment in how
Ahorita del
you rate.
NACC nada más están los primeros 32 items. Y
Sorry.
también en
Make sure you're muted, everyone.
There's certainly a role of clinical judgment in the neuropsychological test score interpretation. There's a role in CDR estimation when people are giving you a functional complaint. And talking about that, do you take it, going back to Jim's comments, you do have to consider, the validity of the respondent and the depth of reporting. So I think this is going to be a challenge. Mostly myself, I'm concerned about subjective cognitive decline, knowing that, almost so many of our older folks have some kind of subjective complaint. Sometimes it's really mild and we dismiss it as age-related complaint. Sometimes we say, no, this is a real serious subjective cognitive complaint here. So I think we'll learn from the experience anyway, but I do think there's no substitute for clinical judgment in the things that we do. But collecting the data in a systemized fashion will allow us to test hypotheses and to move forward.
There are a few questions too in the chat about how sensory impairments, other things that older adults experience that are non-cognitively, how those play into that and how to best capture, if it's hearing loss, vision loss, there's several questions along those lines, how to best capture that in UDS4.
I believe Lisa or Sandy may want to comment on that, but I believe that that's collected in Form C2.
Yeah, I
Yes.
think we added some questions to get at the sensory impairment. Can't remember the exact questions now, but I think we did add those.
Yeah, I think Nina included it in the
Oh,
chat.
good. Thanks, Nina.
Thank you. Yes, Jim, did you follow up?
Yeah, this is actually, I have a question specifically for Lisa. What the cases that you were presenting, and this is something that we've seen very frequently. So when we're reviewing cognitive test performance among our cohort of healthy volunteers for possible impairments, very often our Black participants are getting flagged because of their test scores. And then not every single time, but most of the time when I reach out, those individuals have no subjective concerns. They still are functioning perfectly normally. Nobody has concerns. They're working. And then when they come back for subsequent testing, they either do slightly better or they do equally crappy on the same test. And so my question is, life was a lot easier when I didn't realize how crappy some of the norms are that we currently depend on. And especially when it comes to race differences in test performance, isn't what you suggested with your cases, isn't that going to lead to us classifying a whole bunch of Black participants as being abnormal, of being impaired, not MCI, when in my opinion, many of those people may be perfectly normal?
Yeah, that's a great point, Jim. And it's one that we have struggled with here at our center, which is why our neuropsychologist was making the decision to disagree with the algorithm. And, we didn't have this category in our center, impaired, not MCI. This is now part of NACC. But I do think it's something we need to think about. And I'm hoping that with the social determinants module that we're adding, that we'll be able to use that to help us understand more about these cognitive test scores. But I think we are going to have a large proportion of our underrepresented participants, not just African Americans, Latinos as well, in this category that we're going to have to deal with. And I don't have the answer for that. I think it's going to be a problem.
Jim, speaking to your comment, I'm noticing that there's another comment in the chat about how do we view the relative importance of inter-individual test performance over time versus an individual's test performance relative to available norms. And I mean, this is really the crux of one of the problems. They may not be normal according to our norms, but they don't change and they don't have any problems at home and they're doing fine. So they're normal for themselves. And I'm wondering, to what extent do we need to be looking, not just how do you compare to some norm that may or may not even be good for your demographic, and how do you compare to yourself over this period of time for what you do? I mean, I had people who the first complaint was that mother used to go and collect eggs from the hen coop in the morning and she was forgetting to do that. Now we don't have that on our ADL scale. And that's something very important in that context.
Yeah, and all the people that all the cases I showed were like that, right? They just were not changing over time. And so are they abnormal?
They impaired, right?
Right.
Yeah, I have a problem with that impaired, because it's impaired. Can you be impaired 1 year and not impaired another year? You can.
You're gonna have to wind things down, but we really, really want to thank all of our panelists. Thank you, Dr. Jicha, for leading this. But again, I think we will be taking all the comments in the chat and the Q&A and bringing those to our training webinar on May 14th. So we'll make sure that those questions are addressed, things like, does this trigger queries and things like that. But also, I hope that everyone on the call is thinking about how to use NACC data to study these questions. So like, how do we use the new UDS4 data to see, you know, do all these points support a diagnosis of normal or what the trajectory is. So hopefully these will be triggering questions from all the investigators on the call about how can we use these data to help us refine our diagnostic criteria in different groups of people. So we're excited about that. So thank you everyone for being on the call today. Again, our next session will be in person with our ADRC meeting at the May meeting, and we'll be talking about disclosure procedures. And so Dr. Raman Filipiak from Michigan, Drs. Clark and Chin from Wisconsin, and then we'll have some research participants too sharing their perspectives on disclosures. So we look forward to seeing you all in Austin in May. Thank you.